Ifatu Orangse, and I'm the Secretary of the Education Committee of the Nigerian Society of Anesthetists. And I'd like to welcome everybody here to the webinar today on behalf of the Chairman of the Education Committee of the Nigerian Society of Anesthetists, Dr. Deti Mohammed, and on behalf of the President of the NSA, Dr. Briggs. I'd like to welcome each and every one of us to today's webinar. Today, we're having our second case-based discussion, and this is the 5th session of our 9th webinar series. And today, like I've said before, we'll be having our case-based discussion. This is aimed at helping our residents in preparing for their various examinations. Today, we have a moderator who will be anchoring the program, and she is none other than Dr. Ugwu Euphemia Mbosoro. She's a fellow of the West African College of Surgeons, and she's a consultant anesthetist at the National Ear Care Center, Kaduna. And at this juncture, I'd like to give the floor to Dr. Ugwu. Dr. Ugwu, you have the floor. You can commence. Thank you very much, ma.
Good evening, everyone. Thank you, Dr. Oranisi. Thank you, Madam President, NSA ESCO, and the Education Committee for giving me the privilege to moderate this webinar series. I will also like at this juncture to welcome our facilitators, our facilitators for today's webinar. They are Dr. Adam Ahmad, Consultant Anesthetist and Medical Director, Ture Umar Yaradua Maternity and Children's Hospital, Katsina. The second person is Dr. Galadima Ibrahim Belu, Consultant and the Head of Department of Anesthesiology and Intensive Care, Usman Danfodio University Teaching Hospital, Sokoto. The next is Dr. Ibrahim Joseph Deka, Consultant Anesthetic and Chairman Quality Assurance Committee, Barau Diko Teaching Hospital, Kaduna. And the last but not the least, Dr. Rukaya Abdullahi Sidi, Consultant Anesthetist, Aminu Kano Teaching Hospital, Kano State. As we all know, the time allocated for each scenario is 10 minutes. And we have 5 minutes for the participants to answer the questions, 2 minutes for this facilitator to discuss on the scenario, and 3 minutes for all the other audience to talk discuss on same scenario. So if anyone has any of the participants that is taking any of the case scenario, is having a network problem, the facilitator can call another person immediately to take up or to continue with that same scenario, answering the same scenario. And when you are called upon, please try to be specific, and make sure that if you have a television set or anything around you, you should mute it in order not to disturb the webinar. Thank you very much. And with this, I will call upon the first facilitator, Dr. Adam Ahmed, to take the floor.
Thank you. Good evening, everyone. Thank you, our colleagues and the participants. I have a number of questions from the slide. Question 1, 2, 10 and 15. So I think I will start from question 1. And I have a list of candidates who are expected to participate. So let me start from candidate number 1. Dr. Udo, are you there? UUTH. The question on the screen says, are you there, please, Dr. Udo? Please. If I call a candidate and he's not there, anybody can raise their hand from the list, please, so that to save time. The question, as we can see, an 86-year-old lady with subtrochanteric fracture of right femur presents for total hip replacement. So the question has 3 sections. A, discuss the preoperative management. B, list the techniques suitable for this procedure. Then C, what are the possible complications post-operatively? So if Dr. Udo is there, you can start to attempt.
Thank you, my teachers and senior colleagues. I just want to ask those people that are the candidates to raise their hand up so that our trainers can identify those who raise their hand so that they can answer their questions as others are still joining.
Thank you, Dr. Shoaib. This is a good suggestion, please. Candidates, are you there? We only have 10 minutes for the whole question, please. Dr. Orumade, UUTH, from UUTH. Kasim Bello.
Kasim Bello is here. We have Dr. Leader Joshua. You can raise your hand up and start answering the questions.
Hello, sir. Good evening.
Another here.
Hello, sir.
So please, Sams is talking business, so you have to be confident. Come forward and say what you have. Definitely you will be right in so many respects, and you will get some corrections and contribution from everyone here.
Hello, okay, sir. So good evening, everyone. I'm Dr. Kasim Bello.
Okay, Dr. Kasim, you are welcome.
Yes, sir. Thank you, sir. Okay, sir. First of all,
okay, go ahead.
Okay, sir. This is an elderly man who is been booked for an elderly lady who is booked for subcontract right femoral total hip replacement. So being an elderly, therefore we need to this patient they are at risk of some comorbidities, associated comorbidities, and like cognitive dysfunction. Therefore, perioperative assessment in them with careful evaluation is important. My preoperative management for this patient will fall into history, physical examination, and then investigation, and then patient. So if the patient has some cognitive dysfunction, I will have a reliable informant to take some history. The history, I would like to ask the history around the reason for the surgery and any complication or any sign and symptoms that warrant the patient to have the surgery. I would also like to ask about history of comorbidities. Being an elderly woman, she's at risk of having hypertension, diabetes, asthma, or even cognitive dysfunction in them. So I would like to ask any possible history of comorbidities and then associated complication related to that comorbidities, like history of heart failure, by asking history of dyspnea or exercise tolerance, or any body swelling or orthopnea. I will also ask about history of cognitive and then history of stroke. Besides that, I will ask history of any previous anesthetic exposure. If there is then any complication associated with that, and I will also ask about history of drug allergy. Also, this patients, they are at risk of, or they are kind of patient that maybe they are taking a lot of drugs. So I will ask in details about history of drug or polypharmacy. I will also ask history of denture, if there is any removable denture or any loose tooth. I will also, because if I'm intubating this patient, they are at risk of loose tooth and risk of airway obstruction. I would also like to ask about any history of social, like history of cigarette smoking and alcohol. Then I will ask about, then I will go for my physical examination. For physical examination, I will thoroughly check, do a general physical examination from head to toe, looking for the hydration, pallor, and a level of if there is any fever or cyanosis or fetal edema. I'll also thoroughly check the cardiovascular system, checking for the pulse rate, the rates, the irritability, because they are at risk of having arterial fibrillation. I will also check the blood pressure in spine and in sitting position. I will also check the precordial. And also, I will thoroughly investigate, check the respiratory system. Then I will thoroughly check the airway airway, because they are at risk of having airway difficulty in an elderly. And also, I will check the CNS, or central nervous system, especially the cognitive function of the patient. After having taken this and also some musculoskeletal examination, I will go to my review on investigation. In the review of the investigation, I will check my routine investigation like full blood count, EUCR, urea and electrolytes, and then check for the baseline ECG, and then any chest X-ray. I will also check for any relevant investigation. After then, I will check, I will go to my plan.
1 minute more.
Okay, I will give ASA status, then I will make my plan and anesthesia. I will give pre-operative costing guidelines and the type of anesthesia and obtain consent. So for the part B part of the question, the surgery or anesthesia that is suitable for this kind of surgery can be a spinal or combined spinal with epidural or epidural anesthesia with kind of sedation. I can also give some block like lumbar plexus block or sciatic block or femoral 3-in-1 block, and also is amenable to general anesthesia. So the complication that can arise from this post-operatively, there may be hypotension, pulmonary embolism, there may be fat embolism, there may be hypertension or cognitive dysfunction, and then they are at risk of maybe complication like post-operative delay recovery.
Your time is up. Your time is up.
Thank you
so much. I think this is a good attempt from my own view. So only that some additional comments. Yeah, you really went through the pre-operative management as the question asks, starting from the history, examination, and then investigations. And you take into cognizance that this is an elderly, 86-year-old, as you said, having some challenges right from the pre-op, intra-op. Pre-operatively, dementia is one of the things that could happen in elderly. So as you rightly mentioned, the history may not be taken directly from the patient, because, and I think generally the attempt is okay. You mentioned, but in the plan, you should know that they could be dehydrated, they are elderly, sometimes they don't take adequate fluid. So you fast them and commence them on IV maintenance, and that will even make you to secure the IV access earlier than commencing the surgery. You didn't talk grouping and cross-matching blood because of the surgery. Possibly there could be bleeding that you may need to transfuse. You mentioned the commonly subarachnoid block and some sedation in the patient, but you avoid oversedating the elderly. Midazolam can cause some agitation in them. And then, importantly, you plan giving them oxygen, even though that is a post-operative issue. And then lastly, you mentioned some of the complications. So I think I will leave the floor open with the few minutes that remain for any contribution from the floor. Thank you so much, moderator. Over.
Please, anybody from the floor that has any contribution can raise your hand or drop your question or contribution in the chat box. Thank you.
Good afternoon or good evening. My name is Dr. Adesina. Can you hear me?
Yes, we can hear you, ma'am.
Yes.
Thank you very much,
Yes,
Doctor.
we can hear you.
Thank you very much for your presentation. I think that was a very good attempt. I just wanted to highlight one or two things. This question, whether it's coming as a written or as an oral question, you have to realize that there are three aspects to it, and each carries a mark, and you have to attempt all the aspects. So I appreciate that you were very exhaustive with the first aspect, but you must make time to answer the other aspects. Then in listing your techniques, you have to remember that you have to list all the possible techniques. You can, like you said, do a spinal. You can do a combined spinal epidural. You can decide you want to just do an epidural, and then you can decide you want to do a GE based on your assessment of the patient. So they said list the techniques suitable. So suitability depends on your assessment of the patient. For example, in the elderly, you know that they can have problems with their spine. You've seen patients that have elderly patients that are totally bent, and securing a spinal or instituting a spinal original technique might be very challenging or quite impossible. So you must always entertain the fact that you might need to do a GA, even though it's a lower limb surgery. Then in doing that, even for those that don't have bad backs, but the space or note that the volume will be reduced compared to other regular patients. And then also assessing them regularly to ensure that it doesn't ascend beyond the level that you desire. And finally, in the aspect of the possible complications, I don't know if I couldn't remember you getting there, but delirium in elderly, and like you said, some of them have dementia, they can be quite uncooperative. So the post-operative period can be turbulent in them, and you need to note that there in your post-op management and how you're going to manage pain and delirium and other issues that might arise as a result of those things that we've highlighted in post-operative period. Thank you. Well done.
Thank you. This is a good contribution. And they say, what are the possible complications? You don't just list. List some few things. Because they say what they are asking you to say something about them. So distributing your time fairly among the options based on the allocated marks is very important. It's a good strategy that you have.
Or
Thank you very much, sir. 10 minutes gone. Thank you. So I'm calling upon Dr. Galadima Ibrahim. Please, you can take the floor now.
Okay, thank you very much for the opportunity. I have unfortunate to facilitate. So, and the question still, question 8. Question 8, please. Yes, yes.
Welcome, man.
You see on the screen.
Case-based exam, case-based
destroyed lung distance syndrome, who is scheduled for right pneumonectomy. What device options are available for achieving one lung ventilation? States that list problems of one lung ventilation. So it's allocated. I can't. I don't know. I don't have the list here with me. So the floor is open now for the participants to attempt the question. Hello?
Dr. Galadima, please, can you call on Dr. Leader Joshua?
Dr.
Leader Joshua.
Dr. Joshua, leader.
Good evening. Good evening, my seniors, Dr.
Yes,
Leader Joshua.
You're welcome.
Thank you.
So
Okay,
please, can you attend the question?
Hello, ma.
Hello?
Okay, the question says a 40-year-old patient with destroyed lung syndrome scheduled for right pneumonectomy. The possible devices, the possible device options available for achieving one lung ventilation would include a double lumen tube, a bronchial blocker, and a single lumen tube. Then the second question is the possible list the problems of one lung ventilation. The problems of one lung ventilation include hypoxia, ventilation perfusion mismatch due to patient being under anesthesia. The problems of positioning as well would also be a part of the problems patients will have for while undergoing one lung ventilation. It could also be shunting, and atelectasis as well can also occur in this patient as one of the problems they can undergo while undergoing one lung ventilation. I don't know if I could be heard. I am on transit. Hello?
Sorry, please, moderator, there is background noise. Can you mute all the people that are not speaking, please? Anybody who is not speaking, please mute your device if you have not been called upon to speak.
Okay.
It is the participant that is on transit, so there's nobody.
Okay. Okay, all right. Okay. Continue, please.
If you are driving.
Hello, I can't hear you, sir.
Are you driving?
Dr. Leader, are you driving?
Yes, I'm traveling, sir.
You cannot stop and do the job, or you should allocate to another person, or what? Because you cannot be driving and be attending a webinar.
I'm not the one driving, sir, but I'm on transit. I'm traveling.
Okay. So is that all you can say about the question?
I didn't get you, sir. Come again, sir.
Is that all you can say about the...
Yes, I'm done, sir.
You are done?
Yes, sir.
Okay. Is it time up for him? Hello? Hello?
I can hear you, sir.
No, I'm talking to the moderator.
Has he attempted question A? I only had him listing the problems. Did he attempt the A part?
Comment on that.
So,
maybe he misunderstood the wordings of the question. Because once they say what, it's not just for you to list and move. So it's expected that each technique you mention, you give explanation to it. And how, I remember you mentioning a double lumen tube. So it's not just enough to mention and go. You have to tell us what is double lumen tube and what are the indications, some of the indications, then how do you achieve long separation using the double lumen tube? Even the types of double lumen tube. Because the question says, what device options? Yes, it's expected that you mention the devices and the techniques. So it's not just enough to mention, you have to explain that aspect. So even after stating how to achieve long separation using the double lumen tube, then you have to also say how possibly you can right placement of the tube. Then if you mention the second option, which you said the use of bronchial blocker, similarly on that, you also have to, and how do we achieve the long separation? What are some of the drawbacks of using a bronchial blocker? Likewise, if you are using the single lumen tube, the conventional ETT, if you are using it for long separation. So the question is not just for you to list. You are supposed to state advantages or how to achieve long separation, and that's on that question. Then on the problems also. Yes, there are problems you mentioned that, yes, like hypoxia, ventilation. Hello? 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 Hello, am I connected?
yeah, we can hear you.
Yeah, we can hear you, sir.
Okay. So I was just commenting on the way he answered the questions, or attempted the questions. So, and also it depends on whether you are writing a full essay.
Hello.
Yes.
Time.
Hello? Hello?
Okay.
Hello?
Okay.
Hello? Hello? Hello, moderator.
We can hear you. You, sir. Continue.
But all the same, whatever it is, once they say what, it doesn't mean you should just list. After listing the various options, then you tell us.
Hello, I can hear you. I can hear.
Then you tell us how you achieve the separation technique using each of the option, and also you should tell us also the drawbacks of each option and how it is important in some long procedures. I mean, in some thoracic procedures. Then the issue of listing problems of one lung ventilation also. Yeah, the question stated list. So you listed some problems like hypoxia, ventilation perfusion mismatch, like one lung, acute lung injury also is one of the problems that can arise from using one lung anesthesia, one lung ventilation, in addition to some of the problems we mentioned. So I don't know if there's anything to add on this question from the floor. Hello? Hello? Hello?
Yeah, thank you. Hello, Dr. Ibrahim. We can hear you. Thank you for the as a facilitator to this question.
Sorry, my network, I was interrupted, but I think we have the time for this question has elapsed. We have spent 10 minutes on these questions. Please, can you hear me?
Yes, I think Prof. Prof is already.
Can you hear me? We can hear you, moderator.
Hello.
Hello, moderator. We can hear you.
Yes, can you hear me?
Yes, we can hear you. I was just making a comment. After the facilitator has commented, he asked if there are other comments based on the answer or the response of the candidate. So what I want to say in support of what the facilitator said is that this question is a case of destroyed lung syndrome for pneumonectomy. So if the candidate is attempting, there are two parts. The candidate should have given a brief overview of what is destroyed lung syndrome, what is pneumonectomy, and the other possible indications for pneumonectomy. Then the question is in two parts, A and B. What device options are available for achieving one lung ventilation? I think the candidate did very well in this section. I think he should mention all the possible devices and talk about each one of them. If you talk of double lumen tube, you should say, what are double lumen tubes? How many types of double lumen tubes you have? And now they said it's a right pneumonectomy. You must say, what type of double lumen tube are you going to use? Are you going to use a right-sided or a left-sided? You must say it in answering this question. It's very important. Then if you're going to talk about using a blocker, you must say what it is, what are the indicators, what are the complications and the side effects to the uses, and what have you. So I think that A part was not well attempted. And then when the B part lists the problems of one lung ventilation, yes, actually, I think he listed about 5 or 6 problems, which is okay. But also, when you mention the problems, you should, this is a list question. So you can just say what the problems are. But if you want to get a few marks extra, you should say what the problem is and put a sentence or two to explain or highlight that particular problem you have listed. So that is what I want to say regarding this question. Thank you very much.
Good. Thank you very much, Prof. Thank you very much.
I think the moderator has network challenges. She's being logged in and out. Maybe somebody can step up to help to continue if she's not back.
Dr. Ogu. Hello?
She's back. Dr. Ogu, your network is unstable.
Please,
Ugu, you can type in the chat box who is next.
I am next. I am next, Dr. Ibrahim Joseph Deka. Yes,
okay,
sir.
I think you should go ahead before she gets back.
Okay. So question 7. Okay. Before we flash the question, I would like to call on Dr. Ahmed Sadiq, if he's around, to answer this question. Dr. Ahmed Sadiq. Dr. Nwo for Emeka.
Take the next scenario.
Yes, okay, all right. Thank you very much.
Is that Dr. Who is speaking?
Hello, Dr. Ibrahim.
Okay, Dr. Nwo for Emeka. Okay. So this is your question. Leave the intraoperative concern. Okay, this is your question. Read it for us and then.
Okay,
yes.
So my question is,
Dr. Ibrahim Deka, you can take the next scenario.
Yes, I am on it.
Dr. Ibrahim Deka.
I'm on it, Dr. Ugu. I'm on it. I'm on it. I'm on it. So, Dr. Nwafo, you can continue.
Okay. So the question says, a 25-year-old hemoglobin an SS patient is booked for an appendectomy. This is the intraoperative concerns on how to manage them. Okay.
Okay, I can hear you. Go ahead.
On how to manage them. Okay. So first of all, so this patient is a sickle cell patient. So they are once time they are prone to vaso-occlusive crisis, and they are prone to and also because they are they're always okay, they are prone to abuse of opioids. So intraoperatively, so these patients, to prevent them from going through any of the vaso-occlusive crisis, I would ensure that so intraoperatively, I would ensure that this patient is well hydrated. So I will ensure that adequate fluid therapy is administered to this patient. So that would prevent them from going to a vaso-occlusive crisis. And then also because of their dependence on opioids, is an indication that they require high that they will have higher requirements of analgesics. So bearing that in mind, I would increase the dose of analgesics for that they will be needing intraoperatively. So this patient too also has low hemoglobin, even though they might be stable at a low hemoglobin of about 20%. Well, I would also want to prevent to ensure that that blood conservation. I will ensure to conserve blood, and so I will ensure that the patient comes with at least a unit of whole blood, and then I would put in strategies to prevent this patient from losing further blood, such as if the if such as I could use hemodilution techniques to ensure that they don't lose so much blood.
and I could.
Hello, go on.
Okay. Then I would. Okay. I would also. I would encourage the surgeon to use a blood conserving techniques such as using the electrosurgical unit to minimize blood loss. And I think these are the problems that I can remember and how I'm going to try and manage them.
Okay. You have done quite well. You've mentioned some of the concerns and you've addressed them. Only that I expected you to, like, at least at the beginning, at your start, to briefly tell us what sickle cell disease is all about. That it's a group of inherited disorders of the beta hemoglobin chain, which the hemoglobin S usually contain an abnormal beta globin chain encoded by a substitution of valine for glutamic acid on the chromosome 11. And also it's an autosomal recessive disorder. The management of such patients require a multidisciplinary approach. Like you said, preoperatively, it's good to hydrate our patients well to avoid hypotension. And in setting of our IV line, we have to be very careful in the use of tourniquet, so that you don't tie your tourniquet while you're looking for line for too long, because of the tourniquet effect and the stasis and the ischemia that can lead to crisis later. And also, some of these patients may need preoperative blood transfusion as a simple blood transfusion, or you may need to do exchange blood transfusion depending on the condition of the patient. Also, you need to remember that you want to prevent hypoxemia and hypoxia. So what you need to do for this patient is that you make sure that during intubation, your patient should be well pre-oxygenated, and minimal time should be spent during laryngoscopy and intubation, so that to avoid coughing, barking, laryngospasm, to also prevent vomiting and aspiration of gastric content. You've mentioned about pain management, which is true, and also because many of them are usually addicted, because of the pain, many of them are usually addicted to painkillers. Setting of lines in this patient are usually very difficult. And in the theater, the operating room should be set at a minimum of at least 24%, 24 degrees centigrade, or maximum achievable based on the patient's condition. And also preoperatively, some of this during your history, if you find out that if you ask and this patient is having OSA, obstructive sleep apnea, that means that you may have problem with the respiratory system. So you may need to prepare adequately for difficult intubation and how to take care of the airway. You should also have some warming device available. Avoid overloading your patients. In as much as you are trying to hydrate them, avoid a situation where you will not overload your patient. Also, monitoring is very important in this patient. What you can do for this patient too is that you can use your when you are measuring your blood pressure, you can increase the interval of the measurement so that it will reduce that tourniquet effect on the patient. Pain management is also very important for these patients, not because of the intra-op, but because of the post-op period, where you are trying to avoid.
2 minutes remaining for this question. 2 minutes more.
Okay, so you need to make sure that this patient is well, the pain is well taken care of to avoid postoperative pain problems, so that the patient will not have acute chest syndrome. Okay, I think for now, let me just put a stop and allow the floor to maybe add 1 or 2 things. Thank you. Any contribution, please?
Yeah, thank you so much, Dr. Decker. Yeah, I agree with you that the candidate should have been able to give a brief background, and so you have spoken well in that direction. What I want to say that the concerns are the things to avoid are hypotension, hypothermia, hypovolemia, and hypothermia. And these things are very important throughout the peri-operative period. So even though they said intra-operative concerns, I would have liked to hear pre-op, intra-op, and post-op, and then how to manage them. Yeah, that is my own contribution. Thank you.
Thank you so much for. Okay. Go ahead, ma'am. Somebody wanted to say something. Can I go ahead?
Yes, sir. Is the moderator. It's just that the time allocated for this question is up. It has been exhausted. 10 minutes has gone, sir. Sir, but you can go ahead and say your contribution.
All right, sorry, just a short one. Just to bring to mind that we should be careful with the labeling of sickle cell patients as being addicted. There is a statement there that most of them are addicted. They are not truly addicted. For most pain patients, they are chronic pain patients. So most of the time, their pain syndrome are not properly or optimally managed. And the pain management should be peri-operatively, not just in the post-op, depending on how they presented. It has to start in the pre-operative stage, intra-op, and post-operatively, using all modalities possible for them. Thank you, ma'am.
Thank you very much, sir. Dr. Rukaya Abdullahi Sidi, please, the floor is open for you.
Okay, thank you very much. Can you hear me?
Yes, ma'am.
Okay,
yeah.
thank you. Good evening, Prof. Good evening to our trainers, senior colleagues, and also to the participants. Please, can I have question 5 projected?
Yes, we can hear you. You can go ahead.
Question 5, please. Okay, thank you. So here I would like to read out the question before I call in the candidate. The question says, a 6-year-old boy is scheduled for adenosine selectomy. So the sub-question is to describe your pre-operative management and then list possible post-operative complications and how to manage them. So I would like to call on Dr. Udo Abasinfo. I see the person is on ground. If you could please attend. I know you were called earlier on, but you are not available. Dr. Udo from UUTH.
I'm here.
Okay. Please
Good
go
afternoon,
ahead.
seniors. Good afternoon, seniors. Good afternoon, consultants, senior registrars on the platform. I'll be managing a 6-year-old boy that is scheduled for adenotonsillectomy. My pre-operative management, I want to introduce that adenotonsillectomy is that is common, although it is common in children from ages 2 to 6. However, it is also common in the it also occurs in the adult population. The symptoms of adenotonsillectomy are snoring while sleeping. There could be recurrent upper respiratory tract infection. Patients could also have obstructive sleep apnea, and in very severe cases, there could be right ventricular hypertrophy from the obstructive sleep apnea. The management of these patients will begin from the history. I want to find out the history of when the swelling started, what symptoms the patient presented with. Is the patient snoring? Is the patient having fever? Is there cough? Is there catarrh? Is there difficulty in breathing? Is there? I will also use the stop bang criteria to check for obstructive sleep apnea. So I'll be looking at daytime. I want to find out if the patient's blood pressure has been high for age. Also, I'd want to check the BMI for the patient and know if the BMI is high also for age. Also, the neck circumference of the patient, I'd want to know if the neck circumference is high for age, and I also want to know if the gender is male. Also, I'd want to check for associated symptoms. I want to rule out, cardiac failure, which could be from the right ventricular hypertrophy. So I would ask for difficulty in breathing. I'll ask for autopnea, paroxysmal nocturnal dyspnea, if there is leg swelling, if there is exercise intolerance in this patient. Also, I would go ahead to examine the patient. I would also ask for a past medical and surgical history. I'll ask for history of current drug use and drug allergy. Was there any upper respiratory tract infection? When last was the child treated of the upper respiratory tract infection? I'd also want to find out if the child is asthmatic, if there's a family, if the child is asthmatic, family history of asthma, if the child is a sickle cell disease patient, if there's a family history of sickle cell disease, if the child also has epilepsy, and if there's family history of epilepsy. I also want to find out if there are food or drug allergies in this patient. I also want to find out, I will review the system. I also want to find out if there's previous transfusion, if the child reacted to blood previously. Then I will review the systems. I'll go to the examination, general physical examination findings. I want to know the general physical status of the patient. Is the child in respiratory distress? Is it in painful distress from any cause? Is the child pale? Is he anicteric or icteric? Is it cyanosed? Is it dehydrated? Is there any palpable lymph node enlargement? Any leg swelling? Then I'll go to the airway. I would want to know the range of neck movement. I want to know the malampathy of the child, if the child is cooperative. And I also want to know the interincisal distance for a child that is cooperative for airway examination. The cardiovascular system examination, I want to know the pulse rate, the blood pressure, and also the heart sounds for this patient. The respiratory system, I want to know the respiratory rate. I want to check if the trachea is central. I want to know the percussion notes. I want to know if the heart is, if there is cardiomegaly, and I also want to know. I want to know the breath sounds for this patient. Also, I would examine every other system, and then the investigations I request for full blood count and urinalysis. I want to check for any abnormality in the urinalysis. I want to check for if there is anemia in the full blood count, if there is thrombocytopenia or thrombocytosis, and I also want to check for the white blood cell count, if it is elevated or not. And also I will check for the differential white blood cell count, if there is neutrophilia or not. I will also request for a chest x-ray in this patient. I want to know if there is concurrent respiratory tract infection in this patient. Also, I will request for an ECG if there are symptoms suggestive of obstructive sleep apnea, which may pick up which may pick up a right ventricular hypertrophy in this patient. Then I would assign an American Society of Anesthesiologists physical status classification of at least 2 to this patient. My plan will be to counsel the patient and the caregiver on general anesthesia with endotracheal intubation. Also, I will obtain informed consent from the caregiver. I would ensure fasting guidelines for the patient. Then I will ensure fasting guidelines for the patient. I will also counsel, I will ensure fasting guidelines for the patient. Then for surgery, since the patient would likely not require blood transfusion, so but I would ensure that blood is being grouped and saved for the patient. So this will be my pre-operative management for this patient. The possible post-operative complications of adenotonsillectomy, there could be laryngospasm in this patient. There could be laryngospasm in this patient. There could be laryngospasm in this patient from if there is failure to secure adequate hemostasis, which will cause blood trickling down the airway. It can lead to laryngospasm in the patient. Also, there could be hemorrhage. There could be post-tonsillar bleed after surgery. There could be post-tonsillar bleed in this patient. Also, another complication that could arise would be another complication that would arise would be inability of the patient to ventilate properly post-op. So I would want to manage the post-tonsillar bleed. The complication I want to manage is a post-tonsillar bleed. And managing the post-tonsillar bleed, I will recognize that the post-tonsillar bleed is one of the complications of adenotonsillectomy. Post-tonsillar bleeds will occur, it will occur likely immediately intraoperative, immediate post-op, or it can even occur in the post-anesthetic care unit, or it can even occur within 24 hours of surgery being over, which means it can also occur on the ward. And immediately I see the patient, I would institute the ABC of resuscitation. The signs and symptoms of post-tonsillar bleed will include this patient may be spitting out blood, or the patient may be swallowing blood. This patient also may be unable to breathe. The hemodynamics, the pulse rate may be very high. It will be higher than what is meant for age. The blood pressure also, there may be significant hypertension of what is lower for age. So immediately I see this, inform the surgeon.
1 minute more.
Okay, immediately I see this, I will inform the surgeon, and on informing the surgeon, I will quickly set up 2 wide bore venous access, commence intravenous fluid, ensure there is catheter. I would ensure airway I will suction the blood and then ensure a patent airway. I will also give high flow oxygen. And then I will pass a nasogastric tube for this patient. Then this patient will be wheeled into surgery. A rapid sequence induction will be carried out for this patient using a modified rapid sequence induction, because this is a full stomach, using ketamine, 2 milligram per kg of ketamine. For the dose of this patient may be about 14 kg. So I'll use 28 milligrams.
Your time is up. Thank you.
Thank you very much, Dr. Udo. I think that was a good attempt. You went through the question, the pre-op management, and then you added history with details. Just in addition to what you mentioned, do not forget when you're taking the history, always, because of the age, it's at an age where they're losing their tooth. So always remember to ask for loose teeth. And then the investigations, remember, we're not requesting investigations, we review investigations. And then, like you rightly mentioned, blood, we're grouping and saving blood in case some of the complications happen, like the one you just mentioned, in the post-tonsillectomy bleeding. Then also some additions to the second part. Other complications that could occur include airway obstruction secondary to edema, and patient could have also post-op nausea and vomiting. So remember to adequately prevent that. Then, and the history, remember you were trying to find out whether the patient has obstructive sleep apnea. So because of that, they could also have hypoxia in the post-op period. And then they're also very sensitive to opiates. So the obstructive sleep apnea or the opiates could cause hypoxia. And then when you were treating the complication of post-tonsillectomy bleeding, it was breaking, but from the part I had you mention you were going to suction the air. I don't advise you to do that because remember, if the patient is awake, it's going to be a difficult thing. You're trying to tell the patients to actually suction, open the mouth to suction, because the patient can either spit it out or the patient is going to swallow that. Then also, always remember endotracheal tube was used. That's if you were the one that did it. If you were not the one that did it, of course you can't remember. So always review and then check the size of the ETT and then whether the first anesthesia was eventful or not. You can pick up things from the chat. It saves a lot. So let me hand over to the floor for more additions, contributions, please.
Okay. Yeah. In absence of no other contribution from the floor, I call upon the first facilitator to go ahead and present your second scenario. That's Dr. Adam Ahmad. Please, the floor is now open for you. Thank you, sir.
Question 2.
Hello.
Can we go to question
Dr.
2, please?
Adam Ahmad, please.
I'm waiting for the slide to show
the question. Okay, I called it.
The question is, what is Beer's block? What are the complications of the block? And then C says, describe in details how you will perform Beer's block for the removal of a ganglion in the dorsum of the hand of a man. I think I should call Dr. Ahmad Sadiq from FTH Kazna. Are you around? Yeah, Dr. Orumade from UUTH. Dr. Aliu Bashir, ATBUTH, Bauchi. Anybody you can attempt, please?
Yes, sir. Yes, sir. Yes, sir.
Attempt.
Good evening, my teachers, my senior colleague. I am Dr. Aliu Bashir Adamu from ATBUTH. So I will attempt the question 2. So the A part, it says, what is Beer's block? So Beer's block is otherwise called intravenous regional anesthesia. It's a form of regional anesthetic technique whereby local anesthetic is injected intravenously after applying tourniquet for the patient in order to anesthetize a particular segment of a limb for a patient. So it's usually done for procedures that involve the limb, mainly the upper limb. It said, what are the complications of the block? So the complication of the block are as follows. Number 1, toxicity. because local anesthetic is injected intravenously and high dose is used for the procedure. So if the tourniquet is prematurely released, most likely before 30 minutes of injecting the local anesthetic, the likelihood of the patient developing local anesthetic systemic toxicity is high. So we prevent that by releasing the tourniquet in batches. We first release and then re-implant them before releasing. And also, even if the surgery is over before 30 minutes, we should not release the tourniquet before the 30 minutes. Another one is that we can have a tourniquet pen. Usually for the Bears block, 2 tourniquet are being used, the proximal and the distal tourniquet. So usually the proximal tourniquet is the one that is initially implanted, given time for the distal part to be anesthetized before the distal tourniquet will now be implanted, which is being so if we forgot to use it in the proximal one initially, then the distal one subsequently. Another one is we can have ischemia reperfusion syndrome. If the tourniquet stay for too long, usually the ischemic time for the upper limb 1 hour, for the lower limb 2 hours. So if the tourniquet already taking place in that ischemic area, so when releasing the tourniquet, there is massive washout of this anaerobic product like the lactic acid. So that can cause excessive vasodilatation in the patient, so which will manifest as hypotension and tachycardia in that patient. So we avoid that by minimizing the time we implant the tourniquet. So for the upper limb, we should do it less than 1 hour, and then for the lower limb, we should do it less than 2 hours. Another one is that we can have extravasation of the local anesthetic while we are injecting it. So when we are planning to do the block, we should make sure we use a good vein in the patient. I will make sure that the cannula is inside the vein, so it's intravascular. We should not manage the cannula in that patient. Another one is that we can have inadequate pain relief of the block, solution to general anesthesia and do the surgery on that. So the C part of the question said describe in detail how you'll perform Beers block for the removal of a gamma. So initially, I want to take a quick history examination. I will cancel him on the Beers procedure. I will educate him on how I will do the procedure and then take informed consent. Then after coming to the patient, to the theater with the patient, I will now do my pre-anesthetic. Then I will now arrange my drugs. So the local anesthetic that if it is not available, I will can. Then I will also need cannula, syringes with the 2 tourniquet that I will use, IV fluid. I will also require my multi-parameter monitor. Then drug for resuscitation should also be available, such as adrenaline, ephedrine, hydrocortisone, promethazine, and also I will make available my drug and instrument for GA, so to apply, and also my induction and endotracheal intubation. So I will now take non-invasive blood pressure, pulse oximetry, temperature of the patient, and then electrocardiography. Then I will now go and scrub. I will scrub and wear my sterile hand glove, my face mask. Then I will require a trained assistant. So I will now set intravenous cannula for my infusion on the hand that the surgery will not take place on. Then the hand that the surgery will take place on, I will now use size 20, that's thin cannula. I will set it on the dorsum of the hand of the patient. Then after setting the cannula, I will now place my tourniquet, two of them, the proximal and the distal tourniquet. So first, I will now implant the distal tourniquet, 10 to 20 millimeter mercury above the systolic blood pressure of the patient. Then I will now inject the appropriate dose of the local anesthetic. For example, if I'm using lidocaine, I can use 3 milligram per kg, plain lidocaine. I will now inject it into the vein of the patient. Then I will now wait for 10 to 15 minutes for the anesthetic effect to take place, so that I can now inflate the distal tourniquet and then deflate the proximal tourniquet. Then I will check for adequacy of the anesthesia of the place by loss of pain sensation. Then I will ask the surgeon to proceed with the surgery. So after the surgery is over, I will continue monitoring the patient intraoperatively for signs and symptoms of local anasthenic systemic toxicity or inadequacy or failure of the blood. Then after the surgery is over, I will check the time. If it is more than 30 minutes from the time I inject the local anesthetic, then I can initially deflate the proximal tourniquet for 2 to 3 minutes. Then I will now reinflate it, so that the wash away of the local anesthetic into the systemic circulation will be gradual, in order to avoid local anesthetic systemic toxicity for the patient. Then post-operatively, I will now take the patient to the post-anesthesia care unit, where I will hand over to the nurse in the post-anesthesia care unit up to the time of discharge, when he will be picked for discharge using the modified Algebraic scoring system. Thank you very much, sir.
Yeah, welcome. I think this is a fair attempt at the question. You are able to finish all the three within the time. I think just few observations. Yes. Okay, just some few observations. You said quick preoperative assessment. I think this, you don't have to say quick. You have to assess the patient like any pre-anesthesia patient, looking for all things, detail. So as you find out, within that you can find out any contraindication to the gram per kg, but the concentration should be lower, 0.5 solution. And then IV access, don't forget to secure IV access for fluid administration and resuscitation and all other things intraoperatively, apart from the one that you use for the procedure. So that is mandatory, you have to mention. And then the pressure you are expected to inflate the cuff is 100 millimeter mercury above systolic, not 10 or 20 as you mentioned. So in adult, it should be 100 millimeter of mercury above the systolic. In children, half of that, 50, is okay, but in adult, up to 100 above the systolic blood pressure. There are some precautions that you need to take. Number one is that on no account you should release the cuff before 30 minutes of administration. Some would say 20 minutes. But even if the surgery is postponed after administration of the agents, you have to wait for that time before you release. Then after releasing the tourniquet, you avoid massaging the limb so as to reduce speed and spread of the things you have mentioned. And then the injection site, the cannula should be secured at least 10 centimeters away from the cuff. So the cannula site has to be distal to the cuff at least 10 centimeters away. so as to avoid pushing the local anesthetic under the cuff. And also you should not exceed that 3 milligram per kg dosing of the lignocaine. Okay, so these are some of the precautions you need to take. And you have mentioned the complications, very good attempts. I think I will allow for any contribution from the floor. Thank you, moderator.
It looks like the moderator is not on board. Maybe she's having a network challenge.
Okay, so if there is anybody that wants to contribution to the BS block. So in the absence of any, I think because of the time, perhaps before she joins,
I think the next facilitator can come. Let's take the last question. Can have some remarks from the president and also the PRO, and then we close. So I don't know who is next.
Second facilitator, please.
Hey, and the next.
Second.
Okay. The last question on my list, or the last question. Hello, sir.
Yeah, go ahead. That will be the last question.
Okay, the question is, may I have question 9 projected, please? Question 9. I need question 9 projected. Hello?
It's on the screen.
It's not on my screen yet.
It will come.
Yes. Okay. The question 9 states that a patient scheduled for an elective surgery suddenly developed an anaphylactic reaction following induction of anesthesia. But what clinical features suggest anaphylactic reaction? Then the second part is outline what actions should be taken following an anaphylactic reaction. So on this question, I would like to call Dr. Bukola from Ilorin to make an attempt.
Good evening, sir. Good evening.
Yeah, good.
Consultants, senior residents, and fellow residents present. My name is Dr. Okoyinbo from University of Ilorin Teaching Hospital. I'll be attempting number 9 question. And the question says, a patient is scheduled for an elective surgery, suddenly developed an anaphylactic reaction following induction of anesthesia. And the APAT states that what clinical features suggest an anaphylactic reaction? So by way of introduction, I would like to say that anaphylaxis is one of the critical incidents that can occur in a patient that is undergoing a surgery. And it could be from a couple of things. It could be from the anesthetic medications. Some may be reacting to latex in glove, and then some it may be because of their background medical condition, like it could be from people that are predisposing to developing anaphylaxis, like those that have atopy. So for the features that I would suggest that, first we'll notice that the patient might develop a reduction in saturation, which will be displayed on the monitor of the capnography, showing a reduced such SpO2 as well as a raised EtCO2. We also notice tachycardia. There may be tachycardia from increased heart rate. Then the there may also be hypotension, because some of these anaphylactic reaction may result from a widespread vascular dilatation, so it will present as hypotension. May also notice the noisy breathing, maybe wheeze on chest auscultation as well, and then pictures. Okay, so so these are things we'll be looking out for, and the suspected cause will be depend on when this is noticed. And it could be immediately after induction. In this case, we may be either suspecting latex, or it could be from local anesthetic, from a muscle relaxant, which is a common culprit. So the actions that we need to take following a incidence of anaphylaxis is first to record troubleshoot to find out why the patient is desaturating. We have to check machines if we are delivering enough oxygen. We also need to confirm the dose of the medication and the name of the medications that were given for induction. Then we also may need to deepen anesthesia, especially if there is a sign of a bronchospasm, which would say with a noisy breathing and the increase in airway pressure from the machine ventilation. Then we will also have to give, after deepening anesthesia with inhalation, which is expected to dilate the bronchioles, then we can go on to give specific agents that may help to reverse the reaction. We stop administration of neuromuscular blockers. In this case, we'll give steroids. We can give hydrocortisone. We can give antihistamine, the case may be. We need to also increase oxygen saturation, or increase FiO2 in order to increase tissue oxygenation. Then we need to inform the senior around us, as well inform the surgeon, so that we can go on to take blood samples to do blood investigations in order to ensure that we don't have any organ reaction from the anaphylaxis. Then we may need to also, okay, that's all, sir.
Okay. Okay, thank you for that attempt, Dr. Bukola. I have some comments on your approach to the, first of all, the topic, then making an attempt to outline the clinical features. But it's important also during the course of introducing the topic, you should also try to define what is anaphylactic reaction, and even the type of hypersensitivity reaction it is. Let's say just say exaggerated response to an allergen, which is mediated by type 1 hypersensitivity reaction. So if you, in addition to what you have mentioned earlier, then you try to also attribute it to the incidence to anesthesia in terms of the drugs we use in anesthesia. What are those drugs, possible drugs that may cause anaphylaxis, that may be associated with anaphylaxis, right from your antibiotics, your induction agents, your muscle relaxants? Just mention, these are some of the drugs that are associated with anaphylaxis, especially that this patient had the anaphylaxis following induction of anesthesia. So it's important. Then by the time you asked to say what clinical features. It's not just to say hypotension, tachycardia, bronchospasm, and just like we said earlier, once they say what, it's not just to list. You should try to attach some few sentences to whatever point you attach, just to elaborate or to explain the features.
Okay.
Like,
all right, sir.
yeah. Then also the issue of the actions you need to take. You also tried by mentioning the possible management strategies. But just like you said, you stopped the agent that you think is the culprit of the anaphylaxis. In this condition, the anaphylaxis or possibly the patient is not yet intubated after it. So if the patient is not intubated, you try to, as much as you can, intubate the patient. Then you have to put the patient on 100% oxygen. Also, you forgot to mention that this patient should have adrenaline, because it's one of the first line drugs used for management of anaphylaxis. It helps to so it's important. Then just
Thank
like
you, sir.
antihistamines you mentioned are also important, because if you look at the pathophysiology of anaphylaxis, so there is all this histamine release, and all this happens. So most of the effects is coming from the histamine releasing. So by giving it antihistamines, you will take care of that. Both H1 and H2 receptors blockers, like ranitidine and the H1, just like you said, give antihistamine. Also, the steroids are also important. So, but overall, you need to, I think you have done well by, from my assessment on this question. So if there are other comments from other senior colleagues and colleagues, I think they are free to make their comments or contribution to this attempt. Thank you. Yes. Oga, hello? Sorry,
yeah,
sir.
Ogumbi's hand is up.
Yes, sir. Yeah, welcome,
Thank you very much,
Speak.
Mr. Moderator. And very big thanks to Dr. Dati, the chairman of the NSA Education Committee. I just want to pass a comment on the BS block that was answered very, very perfectly by the doctor from Katsina State University Teaching Hospital, I believe.
Yeah.
However, there are controversies as to the blood pressure above which the systolic blood pressure should be inflated. Some say 30 millimeters above the systolic blood pressure of the patient. Some studies actually say 100 millimeters of mercury, as outlined by the moderator. However, generally speaking, 50 to 100 millimeters of mercury is assumed to be in the right range. The outcome is all for the brachial artery not to pulsate at all. That's the reason for inflating both the distal and proximal 50 millimeters of mercury. Also, for those who are interested in browning points during the orals, it's important to state that prilocaine is the ideal choice of local anesthetic. And of course, if you don't have the prilocaine, then lignocaine. also mention that these two drugs should not contain adrenaline. Once you say should not have adrenaline, then for sure you have some browning points allocated to you. I think these are just my comments, but the doctor answered the IVRA very, very perfectly well. Thank you very much. Over.
Thank you, sir. Thank you, sir.
Thank you,
Over
sir.
to the moderator, sir.
Yes, the
sorry,
moderator.
if I may, Dr. Galadima.
Yes, sir.
Yes, the person that answered the anaphylactic reaction question, she did talk about deepening anesthesia as a means of managing something. I don't think that's conventional. We have a patient who is already hypotensive. Okay, so deepening anesthesia would worsen the patient's condition. So I think that should be cancelled from ahead.
It's not appropriate. I agree.
I think,
Dr. Alatu, if I may come in.
I think the reason why she mentioned it because she didn't thought of giving adrenaline. Because if she had adrenaline, that would have taken care of the bronchospasm as well. So maybe that's why she thought she could use inhalation agent to achieve.
It will worsen the patient's condition with hypotension.
It's noted. Thank you, sir.
Yes, I think if I might add to this discussion on anaphylactic reaction, I witnessed two my entire practice. I mean the major ones, the type 1. One I just gave, it's a 40-something-year-old man had a fracture in the bridge of the nose, and it was a 30-minute procedure requiring just general anesthesia. I gave, that was about 10 years ago, or more than that. I gave atropine, thiopentone, succinylcholine tube in. Then the pulse disappeared. My hand is always on the superficial temporal, always. So the pulse just disappeared. At the same time, I remember maybe Dr. Akito is on the call. He came in to ask me for something, and I shouted at him, he should start CPR, he should join me quickly. And it took us like an hour trying to get rid of the water in the lung, which is pinkish in color. And he stayed like, we ventilated him in the ICU for like 2 weeks and stayed up to about 40 days in shortly after laparoscopy and dye test, I wasn't there. I came down and I asked the consultant, why is he leaving? He said the woman had no money. I left, and then somehow she got money. She came, and well, she died on the table. Tube was in there. You could hardly see the tube because of the edema. So it can be that severe. We have some students we have had, they were students rotating. They said, some of them were saying they will not do anesthesia. So it's really serious. So we reviewed everything and we did everything. What we said, what we could do is just maybe to draw adrenaline and there, but anaphylactic reaction, type 1 is equal to adrenaline. Just remember that. That's my comment on that. Thank you.
Thank you. Thank you, sir.
I don't know if, yeah, all right. The moderator, I think, is having serious challenges. So I'm taking over in her absence. We took just the last question, unfortunately, because of time. I want to say that we are planning for the resident. Now that you have a resident rep on the ESCO, and what we are trying to bring out is that there will be regular tutorials among the residents, and then they can talk to any trainer in Nigeria or outside Nigeria to join them, just to hear them. So it will be as frequent as possible. And then we can always cap everything up with 2 or 3 webinars like this with senior colleagues that is well organized like this. So we will watch out for the information. It's likely to start as early as June, or even much earlier than that. Okay, so that is what we are planning to make the most of it. I want to call on on this call. Well, we have Professor Muhammad Aminu Muhammad, a pediatric surgeon, and the national president of the Medical and Dental Consortium. You're welcome, sir, and thank you. And if you have comment, you can say 1 or 2 words, please. If you are still on the call. Professor Muhammad. Okay, so we also have, I think I've seen Professor Eshiet. Hello. Professor Lori, the faculty chair. Hello? Oh, okay, Professor Muhammad, please go ahead.
Hello, Dr. Leti, can you hear me?
Yes, we can hear you.
Good evening, everyone. I want to congratulate, and I want to continue to congratulate Anesthesia for this laudable program. It is not only beneficial to anesthesiologists, to some of us that have interest in anesthesia as a surgeon, it is all once we have time. I want to definitely tell you that other specialties are making effort to emulate what you are doing. It gives a lot of mentorship in particular, and then it also puts everyone on the right path, having the gurus in the profession present all the time. I want to appreciate our senior colleagues for sparing this time every 2 weeks to be here. Congratulations. Thank you very much.
Thank you, President. If the faculty chairman or chairs are here, I know Professor Lori, I've seen her some time, and Professor Sadiq, please, you have the floor. Professor Lori, ma'am. Okay. If Professor Sadiq, Abubakar Sadiq, Chair National. Okay, General Ogunbisa, I know you talk, but that is your right on as a participant from the floor. Now, as a senior
Thank you very much,
you have the floor, sir.
Professor Dati, for coordinating this series of webinars. And I'm so happy and glad that we're having other very senior colleagues from other specialties being present at our webinars, showing that indeed it's a multidisciplinary webinars that we're having. And this goes to show that we can work hand in hand together with our colleagues, not only in the theater, but also in the wider medical space. I congratulate the president of the Nigerian Society of Anesthetists for being the overall personality in charge of this webinars. And I also want to wish all participants, especially the residents in our midst, all the best as they continue to be part of this series of webinars by the NSA. Thank you so very much. God bless. Over.
Thank you, sir. Dr. Adeshian, President, Society of Specialists. If you're still around, please. Dr. Adeshian.
Thank you, sir. Thank you very much. I want to for these presentations. They are educative and very instructive for our residents, especially the ones going for exams, and even for us to remind ourselves of all these different subspecialties and specific procedures, anesthesia for specific procedures. Thank you very much, and I wish all the residents the very best in their exams. Thank you.
Thank you, Madam President. Professor Elizabeth Oboli Nwaso, immediate past president, NSA, and the current president of the Society of Obstetric Anesthetists, Nigeria. You have the floor.
Thank you, Dr. Odeti. That's a very good one from the committee. It's really very laudable, and it keeps well done that there were more facilitators. Also, that the spectrum of the questions, part one and membership, and that is laudable. And also that the keeping the timing and also reminding us of how it is really very commendable. The President, Dr. Briggs, for keeping up with the tradition. A busy schedule, just finishing one exam and probably 1 week, then step to have this interactive session with the residents is highly commendable. I want to encourage everyone to try and make good use of it. And for both trainers, kudos to everybody that participated. And then I think going forward, which more regular in the scheme of affairs, because it seems to be a very encouraging way of teaching and learning and unlearning, and making corrections and that we are doing and dropping the negative ones. So I salute everyone for the high caliber of facilitators and residents and all. Well done, and thanks for everybody's participation. I also appreciate the presence of all the senior people that are here, especially the MD Khan chairman that was able to make time. Thank you, everybody, and well done. Have a good rest of our.
Thank you very much, Madam IPP. Dr. Olateju, I think you have to say, if you are still around, say something from the SSPN. And we were wrote to me because I couldn't see Oshinake from the Critical Care Society. Please, in that order. If you are around, please say something. Dr. Olateju, are you, if you're around, from the Critical Care Society of Nigeria view? Let me proceed before I allow. Thank you very much. The moderator, and also special thanks to the resident rep who was fighting between the education committee and the residents. So we thank you for your effort. Please continue to do that. We will discuss more on what I mentioned earlier. Take place in Abuja. There is All Africa Anesthesia Congress, Africa. please try to be checking for info plan your trip. Then have two important events coming in 29th and 30th May, I think. Yeah. And also there is a 9th scientific conference and annual general meeting of the association, I mean the society, 9 to 11 July. About the same time in Kano, you have the Nigerian Association for Cleft Lip and Palate Fifth Scientific Conference. I think it's also is 9 to 12 July. There is a clash, but please make plans to attend these conferences. Thank you very much. And I will hand you over to the PRO for some announcements. Dear PRO, please.
Thank you, sir. The PRO has some challenges with its network, so I don't think he has.
Good evening. Sorry.
Who is around?
Good evening, sir. Thank you very much, sir. Thank you, our trainers and our teachers, for being part of today's webinar. I just want to update us on our upcoming events. The NSA OGM will be coming up either in June or July. The date will be announced to us later. While the All African and the Co-60 Enugu State, and the theme is workforce well-being. Thank you very much.
Thank you very much. Once again, we want to thank trainers, very senior colleagues and mentors. Thank you all. To improve, God bless you all. Thank you.